Hello, I'm Dr. Libia Scheller. I'm the Medical Director at the Institute of Medical Education and Research, and we are reporting to you live from the 2010 American Society of Clinical Oncology annual meeting here in Chicago. And we are so pleased to have Dr. Bradley Monk from the Creighton University School of Medicine in St. Joseph's Hospital in Phoenix, Arizona. Thank you so much for being with us today. This is really, truly exciting times for ovarian cancer patients, and I think also from the point of targeted therapy and looking at new genes that are actually play a role in the in the progression of ovarian cancer. Because tissue is collected in this particular trial, I think in the future we have a lot of work to do, right? There's a lot of work to be done to look at the genes that play a role and whether we can target it. So in the here at ASCO, that was definitely the blockbuster news for ovarian cancer. But there was also other presentations on other agents that show promise in the area of ovarian cancer. Can you please comment on that? List what they are,
sure.
What they're targeting actually,
sure.
and where we are in their development.
Probably the next most exciting targeted agent are the PARP inhibitors.
Yes.
And no question, GOG 218 set the stage for angiogenesis molecules. There are at least probably 4 or 5 other randomized phase 3 trials now looking at not only bevacizumab but other anti-angiogenesis drugs. But PARP inhibitors, we've all heard about them, but none are approved. Mm-hmm. And probably the one that's farthest along is olaparib. And at this meeting, there was some interesting data on that. Mm-hmm. Kind of like, and this is really interesting, kind of like that bevacizumab works as a single agent in ovarian cancer, olaparib at this meeting was shown to work as a single agent. Okay. You may say, well, great, of course, PARP inhibitors are great.
In what patient population was that?
In patients with BRCA germline mutations. But it didn't work or didn't show activity in breast cancer patients, okay, let me back up. So it showed single agent activity in BRCA germline mutations with breast cancer, single agent activity in BRCA germline mutation ovarian cancer, but it showed single agent activity in high-grade serous tumors, which have a level of BRCA dysfunction not related to BRCA germline mutation. But it did not show activity in triple-negative breast cancer as a single agent. Let me say this again because I might have confused you. So PARP inhibitors work the best in patients that have BRCA germline mutations. But as we saw at this meeting, there are other ways that BRCA can be dysfunctional, epigenetic mechanisms, somatic mutations, and so on. And so in those patients, PARP inhibitors should work, and they do in ovarian cancer. And the phenotype is high-grade serous tumors, but they may not in triple-negative breast cancers, even though there may be some BRCA dysfunction unrelated to germline mutation. So that I hope I explained that well enough. That is an important observation. Again, a higher level of activity for PARP inhibitors in high-grade serous tumors without a germline mutation than in triple-negative breast cancer without a germline mutation.
And that's important to know because, there's been a lot of information that's come out with PARP inhibitors for breast cancer. And it truly, as you can see, works very differently in ovarian cancer.
That's exactly right. That's the bottom line. So PARP inhibition is probably the second most excited targeted agent. The third drug might be a drug called farletuzumab. The final version of the phase 2 that was the rationale to do a phase 3 trial that was presented at this meeting. The phase 2 trial presented at this meeting was a single-arm trial, adding it to carboplatin and paclitaxel in recurrent ovarian cancer. Now, farletuzumab is a drug that is an antibody target against the folate receptor. Folate receptor is preferentially overexpressed on cancer cells, but particularly ovarian cancer. So it is really a nice opportunity in unselected patients to target a tumor antigen, if you will, and to add it to chemotherapy. So the results of this study, so it showed about a 65 to 70% response rate in recurrent ovarian cancer, so with carboplatin and paclitaxel. It's unfortunate that it wasn't a randomized phase 2. It would have been better if they would have taken carboplatin, paclitaxel, carboplatin, paclitaxel, farletuzumab, and compared them, but they didn't. But I think 65 to 70% response rate is enough of a signal to justify the phase 3 trial of those same arms.
Okay.
So that's exciting.
That trial is underway?
Underway and enrolling well, has over 100 patients, that's right.
And what about any other agents that you see on the horizon?
So there were a couple of randomized phase 2 trials. Those are easier to interpret than these single-arm trials.
Sure.
There was one looking at AMG 386. AMG 386 is a peptibody based on the FC region of an antibody. Said another way, it's just a molecule that binds and inactivates angiopoietin. So, VEGF, bevacizumab, drives angiogenesis, but there are other drivers, angiopoietin. And there are other ways to bind and inactivate other than antibodies, peptibodies. And so that strategy was explored, this time in a randomized phase 2. Paclitaxel versus weekly paclitaxel, weekly both ways, and AMG 386. So it's easy to compare. And there was an improvement in progression-free survival, and so that's going to stimulate soon a randomized phase 3 trial in that space. So I think that that's an easier study design. There was another single-arm phase 2, though, that people are excited about, and that's Nectar 102, and NKTR. And Nectar 102, again, single-arm, but in a heavily pre-treated group of patients, had a response rate of about 23%. So that generated a lot of information, a lot of excitement. But again, it was a single-arm trial. You kind of wish that they would have compared it to something. But because of the heavily pre-treated group, it's exciting.
Wow. So, even though there was positive data here in a phase 3 trial with an angiogenic agent, it looks like we also have other agents on the horizon to keep an eye on that hopefully will give a much better clinical benefit in the future. So we're really excited about all these new developments at this year's American Society of Clinical Oncology, and thank you so much for this interview and for enlightening us all as to all the exciting news coming out of ASCO. Thank you.
Thank you for having me.